Hi, welcome back. So for today's video, I am going to be talking all about sexually transmitted diseases and pregnancy. Both are related to reproductive health, but they're also two topics that really seem to be prominent on the nurse practitioner's board exam. So as always, there's a lot to cover because let's face it, primary care dives into every facet of our patients' lives. And therefore, my goal is going to be to focus on those key points and clinical pearls specific to the board's exam and for novice NPs entering into practice. I will discuss all of the STDs that you need to know and also how to properly manage the pregnant patient in primary care. At the end of the video, I of course included a dump sheet to help supplement your studies. Don't forget to leave me any questions that you might have, and also please subscribe to this channel if you have found it helpful in all of your studying. Now on to reproductive health for women. So I figure first we'll go ahead and start with the STDs and get those out of the way, and then we'll move on to pregnancy. So first up is chlamydia. So the majority of chlamydia infected females are actually asymptomatic, although some do present with discharge or abnormal bleeding. The most concerning complication when it comes to chlamydia is the development of pelvic inflammatory disease, which can lead to a whole other slew of problems, including infertility, ectopic pregnancies, chronic pain. So because the majority are asymptomatic, then routine screening is recommended and should be offered to all sexually active patients that are high risk of infection or having complications from chlamydia. So the diagnostic test that you need to know is going to be the nucleic acid amplification test, or look for the acronym NAAT. The treatment for this is, first line is azithromycin, 1 gram PO 1 time. There is an alternative there. If they are pregnant, then you do need to do a test of cure in 3 weeks after completion of the antibiotic. And then again, they recommend that you check in the 3rd trimester to confirm that the mother is still free from the chlamydia infection. Also, you're going to want to test for any concurrent STDs. You'll want to treat the partner and educate the patient that they should abstain from sexual intercourse for 7 days. Also, there's a couple things here. The Fitzhugh-Curtis syndrome. This is a rare but serious complication, and they'll come in with right upper quadrant pain, and it's because there's inflammation of the liver capsule. So that's a pretty serious complication that could pop up on your boards. And then also this is a reportable disease to the health authorities. So next up is gonorrhea, and this has very similar symptoms that chlamydia has. And also they're both diagnosed the same with that nucleic acid amplification test. So they could be asymptomatic, they could have itching or discharge. Treatment for it is an IM of ceftriaxone plus azithromycin to cover for chlamydia, because if they are positive for gonorrhea, then you will treat for chlamydia too. That is always true, and that's important for your boards. And then the reverse of that is not true. So if they're positive for chlamydia, you won't just treat for gonorrhea. But if your patient is positive for gonorrhea, then you should also treat for chlamydia. Gonorrhea, it can become a systemic infection if it's left untreated. An example of how a patient might present if they're having systemic symptoms would be symptoms of gonorrhea, but then also a swollen joint. So there's no test of cure if the symptoms resolve as they are expected, and this is also a reportable disease. So condyloma acuminata, also known as genital warts, and this is a manifestation of HPV. So 90% of these are HPV 6 and 11, which are benign. They are not the malignant types that we're concerned with, which are HPV 16 and 18. Those have a much higher risk for cervical cancer and definitely something to be on the lookout for. So symptoms of genital warts include flesh-colored, cauliflower-shaped, pedunculated, flat, or papular growth. They're most often found on the genital pelvic region. So up to 40% of these actually resolve on their own, but there is some treatment listed there as well, imiquimod or cryotherapy, surgical excision, a couple different options there. And then the last virus here is the herpes virus, and there is type 1 and type 2. Type 1 is typically an oral infection, and then herpes virus type 2 is where it is on the genitals. Symptoms, they include acute onset of small vesicles on an erythematous base that rupture easily and then evolve into painful ulcerations. So you can diagnose this with a PCR test or by doing cultures, but the treatment is going to be acyclovir or valcyclovir. Alright, so this next slide here, a few more sexually transmitted diseases. Pelvic inflammatory disease, this is what happens when chlamydia or gonorrhea are left untreated. So you'll diagnose these patients based on their HPI, their signs, and their symptoms. Indications for treatment include a sexually active female that has pelvic pain, cervical motion tenderness, or adnexal tenderness, which according to Leak is actually the most sensitive finding for pelvic inflammatory disease. With these patients, it is better to overtreat. So long-term complications of this are really increased if we delay our treatment. So it's better that we just go ahead and treat, and we're going to cover against the likely pathogens being chlamydia and gonorrhea. So treatment includes ceftriaxone plus doxy, and then UpToDate actually recommends that you add on metronidazole as well to cover for anaerobic coverage, and then you'll follow up with these patients within 72 hours to confirm that the treatment is effective for them, because if they're not improving, then that warrants a referral to the hospital, possible IV antibiotics, and a further workup. So vulvovaginal candidiasis, or yeast infection as more commonly called, white curd-like vaginal discharge, itching, erythematous, these are the things that we're going to see that the patient comes in complaining of. Diagnosis is made using a wet prep, and pseudohyphae are going to be observed. Treatment is one of the azoles, so they can get monostat over the counter, but then also there is diflucan, which is given with prescription. And then the last one here is trick or trichomoniasis, I call it trick. But symptoms include itching, dysuria, a gray-green discharge, and then that quote-unquote strawberry cervix. So on the microscope, it'll show mobile protozoa with flagella and a large amount of white blood cells. Diagnosis is made again with that nucleic acid amplification test, and then they're going to be treated with the metronidazole, 500 milligrams twice a day for 7 days. Alright, so this slide here discusses bacterial vaginosis and endometriosis. Neither one is a sexually transmitted disease, but they are conditions that you want to be on the lookout for, of course, in practice and in boards. So BV symptoms include that quote-unquote fishy odor and copious amount of white discharge. AMSL criteria for diagnosis is preferred, and these are the things that they need to have in order to be diagnosed. Thin gray white discharge, vaginal pH greater than 4.5, a positive whiff test, and clue cells on a saline wet mount. Treatment, again, is metronidazole, and these patients need to be educated that they should not have sexual intercourse until their treatment is completed. And then endometriosis, this is when endometrial tissue actually grows into the surrounding structures, and it can cause women a lot of pain. So signs and symptoms, this is going to be the reproductive age woman with dysmenorrhea. You might be able to palpate a mass, tenderness with palpation. These patients will want to get an ultrasound, but these patients will also be referred to a gynecologist. Definitive diagnosis is made with biopsy of lesion, but you're not even going to worry about that because these are being referred, unless, of course, you're in OB-GYN. But treatment for these patients, a great treatment for these patients is going to be birth control, and this will help with these symptoms, also NSAIDs as well. Alright, so next is syphilis, and this is definitely something that you want to know a bit about before entering into your boards. Broken into 3 phases: primary, secondary, and tertiary. Primary is when they present with the painless canker with well-demarcated indurated margins. Secondary is when they have condyloma lata, which should not be confused with the condyloma acuminata, which is HPV genital warts. This is the secondary phase of syphilis. And then also they'll have the non-pruritic maculopapular rash, and this presents on the palms and soles, and that's important to remember because that's a defining characteristic. And then tertiary is going to be where they have the neurosymptoms. Obviously this becomes systemic if it's left untreated. So we'll screen those who are at higher risk: men who have sex with men, anyone presenting with a genital ulcer or a canker, Those with previous STDs, IV drug users, and pregnant women also get screened for this as well. The screening test that you'll want to know is the rapid plasma region, or the RPR. And if this comes back positive, then we will repeat for confirmation. And if that comes back positive, they are diagnosed with syphilis. Treatment for this is penicillin G, and that is given IM. We'll follow up in 6 months and then at 12 months post-treatment to see that the treatment is working. Effective treatment is seen when we have a minimum of a 4-fold decrease in their titers. And then an important reaction to know is the Jarisch-Herxheimer reaction, and this is this may happen within a few hours of penicillin treatment, and the patient might experience a self-limiting reaction, but there's symptoms like fever, headache, myalgias, tachypnea, and tachycardia. If the patient has any neurosymptoms or an allergy to penicillin, or they are unresponsive to the penicillin treatment, we want to refer them to infectious disease. Also, this is a reportable disease to the health authorities as well. So what about HIV? Who is going to be at risk for this? Those obviously that have had sexual intercourse with an HIV-infected person, men who have sex with other men, IV drug users, those with history of STDs, homelessness, and a history of incarceration are all risk factors. We'll also want to screen heterosexuals when they have a new sexual partner since their last HIV test. So you'll want to refer these patients as well, but they are treated with antiretroviral therapy, and the way that you know that this therapy is working is if you see that their CD4 count goes back up and then their viral load begins to decrease. That shows you that the therapy is working. The normal CD4 T cell count, which you don't need to know for boards, but I put it there for your reference. Also important to note that mothers with HIV, they should not breastfeed, and this too is a reportable disease to the health authorities. Alright, so now we are moving on to pregnancy, and we're going to start with actually pregnancy prevention, and that is choosing birth control. So number one, we always want to rule out pregnancy before starting any women on birth control. And there's some really important contraindications that you want to know for combined estrogen and progesterone contraceptions. So it's contraindicated in those 35 and older with a smoking history of 15 or more cigarettes a day, or in patients with 2 or more risk factors for cardiovascular disease, including smoking, diabetes, hypertension, if they have a history of venous thromboembolism, if they have any known clotting disorders, history of stroke or heart disease, breast cancer, cirrhosis, migraine with aura, and liver disease. Contraindicated in all of these patients. And then some important points for choosing birth control I listed for you here. So Yaz, that has a higher risk of clotting. Depo and IUD, those cause a delay of return to fertility. So if someone knows that they want to be trying to conceive relatively soon, those are not going to be the best options. There's a black box warning as well with the Depo, and it's that it increases risk of osteoporosis. So it's really discouraged by the research for use greater than 2 years. And then an IUD is contraindicated in women with pelvic inflammatory disease, a current STD, or any undiagnosed vaginal bleeding. So some drug interactions that you want to be aware of with oral contraceptives, and we want to educate our patient to use a backup plan while being treated with the whatever drug it is, including ampicillin, tetracyclines, clarithromycin, St. John's wort, phenobarbital, phenytoin, or antifungals all can interact with the woman's birth control. Postpartum women and breastfeeding women, they cannot use birth control options with estrogen. So there are some estrogen-free birth control options, and those are the IUD, the Nexplanon, the Depo, and then the mini pill or progesterone-only pill. Important with the mini pill is that you need to take that the same time every day, and you need to really harp on that with your patient. If it's more than 3 hours late, they need to take that missed pill as soon as possible, and then they have to use a backup contraceptive for 2 days. And that's if they miss the one pill. If they miss 2 or more days, then they take the most recent pill missed as soon as possible. If they have to double up, that's fine. And then they will discard the remaining pills that they had missed and continue on with that pack, but they have to now use backup for 7 days. And anyone that we are starting on a new birth control, we want to follow up within 2 to 3 months to make sure that their side effects are okay and that they are stable, to check their blood pressure. That's very important. And if everything is kosher, then you are able to prescribe 12-month prescriptions of birth control from there on out. All right, so this slide talks about determining and dating pregnancy. So there is the Nagel's rule. There's 2 ways to do this. I included the one that makes more sense. So it's the last menstrual period plus 9 months plus 7 days equals your estimated delivery date. And then also here are positive, probable, and presumptive signs of pregnancy. So presumptive signs are going to be symptoms that the mom is experiencing. For example, amenorrhea, nausea, vomiting, breast changes, fatigue, and then feelings of fetal movement by her, also known as quickening. Probable signs, so there's Goodell, Chadwick, and Heger sign. Any sign that has a surname in the beginning of it is considered a probable sign. Also, a urine pregnancy test and a beta HCG fall into this category. Positive signs of pregnancy include palpation of the fetus by the provider, ultrasound, and fetal heart tones. So this slide here just has some side effects and then some physiological changes that occur during pregnancy. So the first one here is pregnancy increases the woman's heart rate. And it actually might be a normal finding to hear a S3 heart murmur during pregnancy. Also, the woman's plasma volume increases greatly, nearly 50%. And this can cause something called dilutional anemia. Blood pressure tends to decrease in the first trimester and into the second trimester of pregnancy. And then because of this, sometimes women are able to actually come off of their blood pressure medications during that time if they have hypertension. And then pregnancy is considered a hypercoagulable state, and that's something important as well. Their clotting factors are increased during pregnancy. So melasma, this is something that occurs from high estrogen, and there's a picture for you there to look at. But what it does is it's hyperpigmentation of the face. Typically, this does resolve within a year, but this actually can be permanent as well. And then some other side effects listed for you here: stretch marks, decreased peristalsis, nasal congestion, epistaxis, joint ligament laxity, back pain. One I forgot to put in here, but we should all know: nausea, vomiting. All kinds of stuff come with being pregnant. All right, so there's some important stuff to monitor and screen for in our pregnant woman. So the first visit or confirmation of pregnancy, the pregnant woman will be screened for HIV, chlamydia, gonorrhea, syphilis, herpes, and hepatitis B. Hemoglobin and hematocrit should be checked for anemia, thyroid function tests, specifically if the woman is already has hypothyroidism, because she will more than likely need an increase in her medication during pregnancy. We'll look at blood type and Rh factor, and then of course the pregnancy hormone HCG level. So a positive finding is an HCG that doubles every 48 hours during that first trimester. An ectopic pregnancy might be suspected if that HCG is lower than we expect and it doesn't double as it should. An inevitable abortion is when the HCG decreases rapidly, and also the female has a dilated cervix as well. It's important to note here that we need to be ordering a quantitative HCG versus qualitative, because we need those specific numbers when trending the HCG, so quantitative. Rh incompatibility, this is important to have a good idea of, and I wrote for you here, it's a negative mom that is pregnant with a positive, Rh positive fetus. So mom's body creates antibodies to that Rh positive blood. RhoGAM must be given every pregnancy at 28 weeks and within 72 hours of delivery, and this includes an abortion if this scenario is there, negative mom, positive fetus. So I remember this, it's never good if a mom is negative. That's the quote I would say in my head, because if you have a negative mom, you're going to be treating with RhoGAM. So it's never good if a mom is negative, and that's within 72 hours of delivery or abortion. So second trimester screening, a lot more genetic disorder screening will occur during this time. Something to look out for is Tay-Sachs disease, and this is specific in the Ashkenazi Jewish population. And we screen for this between 10 to 12 weeks. It's rare, but it destroys nerve cells in the brain and the spinal cord of the fetus. So there's some serious complications of this. Also, there might be a question in regards to the fundus. So at 12 weeks, the fundus is above the symphysis pubis, and then at 20 weeks, it should be at the umbilicus. Once that woman is over 20 weeks, then we want to rule out preeclampsia, and we'll do this by using a urinalysis, and we're looking to see if there's any protein present in the urine. If there is, then we will order a 24-hour protein and creatinine. Also, Group B strep will be tested for during the woman's 35th to the 37th week of pregnancy. All right, so this slide I dedicated all to pregnancy and medications. It's more likely that a medication is unsafe than safe during pregnancy. There's very few category A drugs. I listed them for you here. It includes prenatals, insulin, levothyroxine, folic acid, and B6. It's important that we educate our patients that they should take prenatals with folic acid, 1,000 micrograms of folic acid daily if they are pregnant. And then if they're women of reproductive age, then we recommend that they take 400 micrograms of folic acid daily. For hypertension medications during pregnancy, there are a couple that have been deemed more safe than others, including methyl-dopa, labetalol, hydralazine, and long-acting nifedipine. Say, for example, our patient is on ACE inhibitor and ARB, which we know are contraindicated during pregnancy, then we will want to switch them immediately to something like labetalol. An acronym I have for you here, CAMP, C-A-M-P. CAMP safe during pregnancy is for antibiotics, and the acronym stands for cephalosporins, amoxicillin, macrolides, metronidazole, and penicillin. Nitrofurantoin can actually be used as well during pregnancy, but not during the first trimester and not close to delivery, specifically after 37 weeks, because this increases the risk of hemolytic anemia, which then increases the risk of hyperbilirubinemia. So SSRIs that are okay during pregnancy, this includes escitalopram, citalopram, and then sertraline. If they're on something else, they recommend that you try switching to one of these drugs. Diclegis is used for nausea, vomiting, and Zofran is no longer first line. And Diclegis is actually a combination of B6 and Unisom. Important also to note here is that no amount of fetal alcohol or no amount of alcohol is safe during pregnancy, and this can cause something called fetal alcohol syndrome. And there's a picture for you there. I included the physical characteristics that you'll want to be aware of because you might see it in practice and you may see it on your boards. What about vaccinations during pregnancy? This slide is pretty simple, but it includes everything that you really need to know. Number 1, no live vaccines during pregnancy. This includes varicella, MMR, and then the live attenuated influenza vaccine. Not allowed during pregnancy. Yes, however, we want to give them the inactivated influenza vaccine, especially if it's during flu season, and then of course the Tdap with every pregnancy. If they get pregnant 7-8 years in a row, literature recommends that they get the Tdap with every one. And this is to prevent and protect against specifically pertussis, which we know can be so fatal to the infant. Alright, so these next few slides we're going to discuss some pregnancy complications important to know. The first one being gestational diabetes. And a diagnosis of gestational diabetes is made during the 2nd to 3rd trimester. If they have diabetes before that, then this is something called overt diabetes. So we will screen all pregnant women between 24 to 28 weeks for gestational diabetes. However, we will screen women at the first visit if they have a history of gestational diabetes or one or more risk factors present for diabetes, including advanced maternal age, ethnicity, or obesity. And like I said, this is called overt diabetes. And this is identified at the first prenatal visit with either a fasting plasma glucose of 126 or greater or a random plasma glucose of 200 or greater. And then we'll confirm this with another test. But these patients, we want their A1C below 6.5%. So when diagnosing gestational diabetes, there's a 2-step approach that's used most commonly. First step being a 1-hour oral glucose tolerance test. If that's positive, which is indicated with a 135 or greater, then we will follow it up with a 3-hour oral glucose tolerance test. A diagnosis requires 2 abnormal blood glucose findings. And then I included for you here the process and the results for the 3-hour glucose test. You don't need to obviously know this for the exam. That's really in-depth, but there for your reference. Preferred treatment for these patients is insulin. Metformin is also a very reasonable alternative, but we're going to be referring these patients as they need to be managed with OB-GYN. Also important is the Somogy versus the Dawn effect. You should know these terms. So the Somogy phenomenon is a rebound effect. It occurs because the blood glucose is elevated in the morning after having an episode of hypoglycemia at night. So the Somogy is a rebound effect. That is why in the morning time they'll have that elevated glucose. It's rebounding from hypoglycemia. Dawn phenomenon, there's no rebound. They did not have any episodes of hypoglycemia. Their blood sugar is just increasing and they have an elevated reading in the morning. So preeclampsia is a very serious and dangerous side effect that we want to monitor for in our pregnant patients. Generally, this occurs late into the 3rd trimester, typically between 34 weeks and up, and even after pregnancy, up until 4 weeks after giving birth. So a triad of symptoms that we want to be looking out for include new onset hypertension, protein in the urine, and then edema, specifically edematous face and hands. We'll want to take, if their blood pressure is elevated, we want to take 2 separate readings at least 6 hours apart to confirm that hypertension is truly occurring. Other symptoms that they may complain of and to be on the lookout for include headache, blurred vision, and a right upper quadrant pain. Like I said, this is a very serious side effect as it can lead to eclampsia, which is seizures, stroke, kidney failure, pulmonary edema, hepatic rupture, DIC, and then fetal and maternal death. So extremely, extremely important. Only cure for preeclampsia is actually delivering of the placenta and the fetus. So these patients obviously need to be sent to the hospital. So a few more very serious complications of pregnancy listed for you here. Placenta abruptio, that occurs from the partial or complete detachment of the placenta from the uterus. The patient will experience sudden vaginal bleeding ranging from mild to hemorrhaging, and they'll have a hypertonic or rigid, hard, painful, tender uterus. These patients emergently refer to the ER. Placenta previa is when the placenta actually attaches too low and covers either part of the cervix or all of the cervix. These patients need to be put on pelvic rest, and this means no intercourse, no bimanual exams, no intravaginal ultrasounds, and they definitely need to be referred and monitored with OB. Ectopic pregnancy, our patients might come in complaining of lower unilateral abdominal pain, and if they're 6 to 8 weeks from their last menstrual period, ectopic pregnancy really needs to be on our differential. They might have experienced some light spotting, or they may have missed their period. They might have a low-grade fever, but when you have a female in reproductive age and they're having these symptoms, definitely needs to be on your radar. First, you'll get a HCG quantitative, and we talked about why that's important earlier for trending the numbers. Also, if we are suspecting this at all, then we'll be referring them as well, because this can be a very serious and possibly fatal emergency. Risk factors for an ectopic pregnancy includes a previous ectopic pregnancy, current IUD use, and a history of pelvic inflammatory disease. And then a few more terms here for you that are important to understand is threatened abortion. And this is when the woman is experiencing bleeding, but the cervix remains closed. And an inevitable abortion is when the patient is having the symptoms and the cervix is actually dilated and it is unable to be stopped. So what about our pregnant patients with urinary tract infections? So if they are symptomatic, then they'll have symptoms like everybody else, dysuria, frequency, and urgency. Also in these patients, it's important that we want to treat those who are asymptomatic as well, and that's because we want to avoid them getting pyelonephritis. We'll suspect pyelo if they have CVA tenderness, nausea, vomiting, or a fever. These need to be emergently referred to the hospital and managed there. For outpatient treatment, options include cefalexin, amoxicillin with clavulanate, fosfomycin, or nitrofurantoin, but remember, not in the first trimester and not after 37 weeks. And that's because the use of nitrofurantoin after this time, after 37 weeks, actually increases the risk of hyperbilirubinemia. And this can lead to kernicterus, which is essentially brain damage. Sulfas also can lead to, or can also increase the risk of kernicterus. Sulfa, for example, being Bactrim. So definitely something to be thinking about before prescribing medication. All right, the last topic here is a post-pregnancy complication, and that is mastitis. Symptoms include breastfeeding female that has sudden onset of erythematous, firm, tender breasts. They may have flu-like symptoms, and it most commonly occurs those first 3 months of breastfeeding. The first-line treatment is Keflex, and that's if there is no suspicion of MRSA. If we do suspect MRSA, then Bactrim is indicated. If there's an abscess suspected, then also we want to get a breast ultrasound and refer for an IEND. We want to educate our patients to continue breastfeeding or pumping to prevent engorgement, and then also we can encourage them to use cold compresses as well. Alright, so this means that I have reached the end of the discussion. As always, here is the dump sheet to help supplement your studying. This is completely dedicated to pregnancy and covers all of the points that you just have to know for your board's exam. As always, please leave me any comments or questions that you have down below. And if you have any specific topic that you'd like to hear me discuss, then go ahead and leave that down below as well. Also, don't forget to subscribe to this channel if it's helped you in your studying. And take care. I'll talk to you guys soon.